So in this video we are going to talk about adrenergic agonist. Okay, so before jumping into the adrenergic agonist, I want to talk about catecholamines. Okay, so what is catecholamine? So the substances which contain catechol ring are called catecholamines. Okay, so what are the catecholamines? So we have four catecholamines: is noradrenaline, adrenaline, dopamine, and isoprenaline. Okay, so these three catecholamines are endogenous catecholamines. Okay, so there is a question that which catecholamine first synthesized into the body. So first synthesized catecholamine is dopamine, and from dopamine we get noradrenaline, and from noradrenaline we get adrenaline by the enzyme called PNMT, or phenyl and methyl transferase. Okay, and this enzyme is located in the adrenal medulla, right? So only from adrenal medulla we got noradrenaline. In other sites we will get noradrenaline. Okay, so what happens when noradrenaline is released into the synapse from the nerve terminal? Let's think that this is the nerve terminal and noradrenaline gets released into the synapse. Okay, so it acts in the receptor. Okay, and it can be taken up by the norepinephrine transporter back to the nerve terminal, and here this noradrenaline can be metabolized by monoamine oxidase. Okay, it can also metabolize by catechol or methyl transferase when it is absorbed into the plasma. Okay, here I am going to talk about norepinephrine transporter. So this norepinephrine transporter is also called reuptake 1 mechanism. Okay, and there is also something called reuptake 2. So these two, reuptake 1 and reuptake 2, both reuptake norepinephrine, but there is the difference in site. Okay, so reuptake 1 is located into the neuronal cells, so it reuptake the norepinephrine into the neuronal cells, but reuptake 2 is located into the non-neuronal cells like glial cells and smooth muscle. Okay, and what about the metabolism of norepinephrine, noradrenaline, noradrenaline? So Norepinephrine or adrenaline is metabolized by monoamine oxidase and catechol O methyltransferase. Okay, so by when it got metabolized, it produced a metabolite called vanillyl mandelic acid. Okay, so this vanillyl mandelic acid gets out of the body through urine. Okay, so why I'm talking about this vanillyl mandelic acid? Because we have a condition that called pheochromocytoma. So this is a disorder, pheochromocytoma. So in this disorder, there's increased synthesis of catecholamines. So increased synthesis of catecholamines leads to increased breakdown. Okay, and this increased breakdown leads to increased excretion of vanillyl mandelic acid through urine. Okay, normally there is we have in urine we have 5 milligram per 24-hour excretion of vanillyl mandelic acid, but if we found that excretion of vanillyl mandelic acid in 24-hour is more than 5 milligram, we can say this person is suffering from pheochromocytoma. Okay, here again I'm going to talk about this monoamine oxidase. Okay, so there is two types of monoamine oxidase, is monoamine oxidase A and monoamine oxidase B. Okay, so what is the difference between monoamine oxidase A and monoamine oxidase B? So they both metabolize monoamines, but there is some difference, like monoamine oxidase A metabolize norepinephrine or noradrenaline, epinephrine and serotonin. Okay, and monoamine oxidase B metabolizes dopamine, tyramine and phenylethylamine. Okay, okay, so let's see the receptors, in which receptors these catecholamines act. Okay, so if I talk about noradrenaline is selective to alpha 1, alpha 2 and beta 1. Okay, adrenaline, if I say, it is selective to alpha 1, alpha 2, beta 1 and beta 2. Dopamine, in low dose it is selective to dopamine receptors D1 and D2. We have dopamine receptors D1 and D2. In moderate dose, it is selective to beta 1, and in high dose, it is selective to alpha receptor. Okay. And if I talk about isoprenaline, it is selective to beta 1 and beta 2 receptors. Okay. So let's see what happens when we administer noradrenaline, adrenaline, and isoprenaline into the circulation, and we will discuss about the effects in the cardiovascular system. The other effects in the gastrointestinal tract, in the respiratory tract, in other systems, there it is the effects are similar what they do with the alpha 1 and alpha 2 and beta 1, and here in adrenaline they affect both all the receptors, so they are selective to all the receptors, so the effect is more or less same with them, and we have discussed it about in the previous videos when we talk about adrenergic receptors. So in this video I am going to focus on the cardiovascular system. Okay, so let's see what happens in cardiovascular system. Okay, so norepinephrine, epinephrine, and isoprenaline. Okay. So norepinephrine is selective to alpha 1, alpha 2, and beta 1, right? So by stimulating alpha 1 receptor, it causes vasoconstriction, and it leads to increase in peripheral vascular resistance. So we know that there is two types of blood pressure, systolic blood pressure and there is the diastolic blood pressure. So due to increase in the peripheral vascular resistance, diastolic blood pressure gets increased. Okay, and by acting on the beta 1 receptor, it increases the heart rate and also increases the force of contraction. Okay, and this leads to increases the systolic blood pressure. Okay, so if we see here, we get that norepinephrine increases the systolic blood pressure, increases the diastolic blood pressure, and it should increase the heart rate because it's stimulating beta 1 receptor, but there is an exception that it decreases the heart rate total overall, because when the blood pressure gets increased, the systolic blood pressure and diastolic blood pressure gets increased, the body activates the parasympathetic system, and it causes the vagal inhibition of the heart and leads to decrease in the heart rate. Okay, so if we draw the graph, in heart rate it is decreased. Okay, in blood pressure this is increase in systolic blood pressure and also increase in diastolic blood pressure and leads to increase in the mean blood pressure. Okay, what about epinephrine? Okay, epinephrine is selective to alpha 1, alpha 2, beta 1 and beta 2 receptors. Okay, And now let's see, let's remove this. Okay, so by acting on alpha 1 receptors, by acting on beta 1 receptor and stimulating beta 1 receptor, epinephrine increases the systolic blood pressure, right, as we discussed in the norepinephrine. But it stimulates both alpha 1 and beta 2 receptor, but it is more selective to beta 2 receptor, and that's why it leads to vasodilation, and it causes decrease in diastolic blood pressure. Okay, so in case of epinephrine, it's increasing the increasing the heart rate because it is stimulating beta 1 receptors. Is increasing the systolic blood pressure, but it decreases the diastolic blood pressure. Okay, so if I draw a diagram, in case of heart rate, it is increasing the heart rate, and it is increasing the systolic blood pressure. It's decreasing the systolic blood pressure, so the mean pressure remains normal. Okay. Okay. Let's see isoprenaline. So it is selective to beta 1 and beta 2 receptors. Okay, so by activating beta 1 receptor, it increases the systolic blood pressure, and by beta 2 is increasing the diastolic blood pressure. Sorry, it decreases the diastolic blood pressure because it causes vasodilation. Okay, so in case of isoprenaline, we can see that it causes increase in heart rate because it's stimulating beta 1 receptors, is increasing the systolic blood pressure, but it decreases the diastolic blood pressure. Okay, so in case of this, increases the heart rate, it increases the systolic blood pressure but moderately, and it decreases the diastolic blood pressure. So the mean pressure decreases. Okay. Now let's talk about the uses of these catecholamines. Okay, let's see. So in case of adrenaline, we use adrenaline mainly in anaphylactic shock. Okay, so anaphylactic shock is type 1 hypersensitivity reaction, and it is mediated by immunoglobulin E. Okay, and what happens in type 1 hypersensitivity reaction is the cardiovascular system there is decrease in the blood pressure, and in the respiratory system there is bronchoconstriction. Okay, so what adrenaline does is by stimulating alpha 1 receptor, it causes vasoconstriction, and this vasoconstriction leads to increase in the blood pressure. Okay, and by activating the beta 2 receptor, it causes bronchodilation. Okay. Other uses, like we can use adrenaline in case of epistaxis because it causes vasoconstriction. Okay, in gingivectomy, gingivitis, and also it is used with local anesthetic. So why we use it with local anesthetic? When adrenaline is used with local anesthetic, it constricts the local blood vessels. Okay, so it decreases the absorption of local anesthetic into the systemic circulation. So it prolong the duration of local anesthetic. Okay, but adrenaline should be used with local anesthetic in very diluted form. Like it should be used like 1:100,000 or 1:200,000. Okay, ratio. Here adrenaline is 1 and local anesthetic should be 100,000. Okay. And what are the adverse effects of using adrenaline? So adverse effects are the other effects that are not used in the treatment. Okay, so what can it do? Like it can do mydriasis, because we know there is alpha-1 receptor in the dilator pupilla, so it causes mydriasis. Then it causes constipation. Okay, so and it can cause urinary retention, because it constricts the urinary sphincter and relaxes the detrusor muscle. It can increase heart rate. It can cause hypokalemia, because it increases the potassium uptake by the skeletal muscle. It can cause tremor by beta 2 mediated action. Okay, let's see what is the use of dopamine. Okay, so we use dopamine in cardiogenic shock mainly. So why we use dopamine in cardiogenic shock? So what happens in cardiogenic shock is there is decrease in the blood pressure. Okay, so in high dose dopamine acts on the alpha receptor and increases the blood pressure. Okay, but you can have a question like in this case we can use adrenaline, right? But we don't use adrenaline in cardiogenic shock, because in cardiogenic shock there is a risk of renal failure, because renal output is less, so that it increases the risk of renal failure. So what dopamine do is there is D1 receptor in renal vessels. Okay, so what dopamine do is by acting on this D1 receptor, it causes renal vasodilation, and that decreases the risk of renal failure. Okay. Now let's talk about the adrenergic agonist. So if we classify adrenergic agonist, we can classify it into direct adrenergic agonist and there is indirect adrenergic agonist. So Direct adrenergic agonists can be again classified into non-specific adrenergic agonists, and there is a specific adrenergic agonist. So we have already talked about non-specific adrenergic agonists. That's our catecholamines. Our catecholamines are the non-specific adrenergic agonists. Now let's talk about the specific adrenergic agonists. So, and specific adrenergic agonists, we have phenylephrine, that is alpha-1 selective. We have clonidine and tizanidine. These drugs are alpha-2 selective. We have dobutamine, that is beta-1 selective, and we have salbutamol, tarbutaline, albuterol. They are beta-2 selective. Okay. So these specific drugs can be given orally. Okay. These drugs can be given orally, but the catecholamines can't be given orally. Why the catecholamines can be given orally, but these specific drugs can be given orally? Because in catecholamines they have that catechol ring, and in this catechol ring, or in this catechol ring, let me draw a catechol ring. There is this hydroxyl group. Okay, there is two hydroxyl groups. So in case of phenylephrine, they don't have this hydroxyl group. Okay, so when you have this catechol ring and these hydroxyl groups, it can be metabolized by this CUMT enzyme, and it is located in the, it's present in the GIT and the liver. So it has less or poor bioavailability. Okay, and when you remove these hydroxyl groups, it can't be metabolized by the CUMT enzyme or catecholomethyltransferase enzyme, and it has good oral bioavailability. Oral bioavailability increases. Okay. Now, what are the uses of this specific adrenergic agonists? Okay, in case of postural hypertension, so what is this postural hypertension? So postural hypertension is the hypertension related to the position. When we change the position, okay, when we stand from the sitting position or we sit from the lying position, the gravity pulls the blood. Okay, so to compensate this mechanism, okay, body activates the sympathetic system and it causes vasoconstriction. If this constriction can't be happen, then there is a condition called postural hypertension. It mainly occurs due to some drugs, okay, like antihypertensive drugs mainly, or vasodilatory drugs like calcium channel blockers, or I can say sodium nitroprusside. Okay, so In postural hypertension, we use midodrine. Okay, so midodrine is an alpha 1 selective agonist, and this alpha 1 selective agonist causes vasoconstriction and increases the blood pressure. Okay. Then there is a drug called oxymetazoline. This is also alpha 1 agonist, and it is used topically for nasal decongestion. For nasal decongestion, and it causes the mucosal blood vessels to constrict, and when the mucosal blood vessels constrict, then this nasal decongestion happens. Okay. Then there is alpha 2 agonist like clonidine, and it is used as antihypertensive, so used in hypertension. Okay. And there is the drug called tizanidine, and it is a centrally acting muscle relaxant. Okay. Then there is this beta 1 agonist called dobutamine, and we use this drug in heart failure. In heart failure, the heart fails to pump blood. Okay, it fails to meet the body's demand. Okay, so what dobutamine do is it stimulate beta 1 receptor, it increases the heart rate and also increases the force of contraction and helps the heart to pump blood, so increases the pumping of the heart. Okay. And there is beta 2 agonist or salbutamol tarbutaline. Okay, these drugs mainly causes bronchodilation, and we use these drugs in the asthma. We will talk about it in the respiratory pharmacology in another video. Okay, so that's all for this video, and in the next video we will talk about the indirectly acting adrenergic agonists. Okay.